All right, I hope you thought I was entertaining for that first hour because you got another hour of me. So if I wasn't, then I'm sorry, but yeah, I'm all you guys got. So the next hour, or actually I'm going to try to go through this in about 40 minutes, just to make sure we can get you out of here at 5:15. I've been where you are with the last presentation of the day, and sometimes you're just ready to go. So we'll look at market forces impacting value-based contracting, maturity of value-based contracting strategies, and then the contracting case study example. Just to summarize the last session, I got a few questions about this. I'll say the number one reason why organizations create clinical integrated networks is to find a way to get dollars from these types of contracts that I'm going to go through in a second down to independent providers or other partners. That's, I'd say, the number one reason. Now, certainly you got to have the quality, you got to have the service, the cost needs to be there. You need to demonstrate that. But this is, don't kid yourself, this is an alignment model for health systems and independent physicians to work more collaboratively together with the employed physicians and other providers. Yeah.
I mean, I feel like it's to get the money to the hospital, not to us.
Well, we can have that argument. And I'll counter that by saying, certainly there's capital investments associated with an organization like this. And we're going to go through an example of a distribution methodology that actually speaks to that and talks through how much the hospital gets versus the physicians versus the other network. If the physicians don't feel like the win is there, the clinically integrated network won't work. And so if that's the case, and if that's the perception in the physician community, then the CIN is failing the organization. I've seen just as many clinical integrated networks succeed as I've seen fail. I've seen clinical integrated networks pour $4 to $5 to $10 million in these organizations, and 2 years later fall flat on their just fall flat. And it's those organizations that, one, only put physicians in leadership positions as a perception, as a view, and then decisions are made behind the scenes and then just presented. That's just not a good way of doing it, because in reality, if your physicians aren't aligned with the health system and the health system isn't aligned with the physicians, it's not going to work. So again, a lot of organizations like these have been very successful, and a lot of them have not. And it matters just as much as the market you're in, right? An Alabama clinical integrated network is going to have a significantly different strategy than a clinical integrated network in Ohio. And a clinical integrated network in Ohio is going to have a different strategy as one in California. So again, it just as much as it depends on the organization and the stakeholders being on the same page, it's the same as the market that you're in. Market forces are eating away at the edges. 1 to 5 Americans will be 65 years or older in 2024. Medicare enrollment will grow by 50% by 2030. And Medicare margins are declining at a rate of 10%. Aggregate Medicare margin for all hospitals in 2017. We got a problem, because the next few slides are going to talk about how Medicare and Medicaid are actually growing in terms of the overall covered lives, which is what that also said. But Medicaid, 75 million enrollees. You see Medicare Advantage is growing. Medicare Advantage, I'll argue, is a major opportunity for health systems and physicians today and over the next 10 years. There are premiums being paid for covered lives within MA programs that create a scenario for providers to take advantage of today and over at least the next few years. And Medicare Advantage programs want to grow, and so they're more likely to come to the table with clinical integrated networks than other commercial payers are. And also because they don't have the covered lives, they want to get the covered lives, and so they're willing to negotiate across that. Their negotiations, and we'll go through this in a little bit, are more on star ratings which are driven by quality metrics that they have. Typically, it's 4 or 5 quality metrics that they have. And then they're also looking for coding and documentation accuracy. They get paid based on the acuity of their overall patient population or panel. They want that patient population to be accurately coded, because if they're coded accurately, they could get more revenue for that, and they're actually willing to pay physicians to do risk scores, to do risk assessments, and other things that would allow that to occur. So certainly other areas that MA, all I'm trying to say here is MA is uniquely positioned and has other things to gain in the negotiations, more likely to come to the table quicker. Let's see if I click the right amount of times. Okay, how do you regain lost ground for commercial lives? You can see that there was a narrow focus on specialty referrals in the 90s. Certainly now there are broader efforts. Primary care is a significant area, but you're seeing this attraction to employers and also just consumers in general. But the 2014 national payer mix, you'll see Medicare is at 35%, self-pay 3%, commercial 38%. Our projections show that Medicare is going to actually grow by 5% as a part of your payer mix or your health system's payer mix. So there's an erosion in the commercial lives, which I think makes sense based on that, 1 to 5, 1 to 6 Americans by, I think, 2024. So there's this dilemma that's occurring, which is also why you're seeing all these CMS pilot programs. Their costs are being driven at a rate that's unsustainable. Right now, a family of 4, I think, is paying around $24,000 to $25,000 a year in healthcare costs. That's going to double. If it doubles, that's higher than the annual income of an average family in America. Again, I'm probably preaching to the choir here, but something that we need to figure out. Create a balanced playbook for expanding and retaining commercial volumes. Again, those are the higher paying ones. That's why you're seeing a lot of employer strategies. You're seeing a lot of acquisitions, economies of scale. Size is a big aspect. Access and patient flow. Comment earlier about convenience. Your partners are not just other providers, they're other businesses. CVS, Walmart, Amazon, could be grocery chains. This is an interesting slide around the value of a clinical integrated network. I had this discussion on the break around enhanced referrals. So there's 2 ways to show value in these clinical integrated networks. One, with a check that you're giving to a physician or to a partner based on the value that they provided and the rewards that were received. Another way of showing value is through enhanced or increased referrals. An example of one where, and we go through a case study in a little bit, but in 2014, I believe the physician that was talking to my client, which was the health system, was like, what am I getting out of this? It took about 2-3 weeks. In 2014, the guy says, look, in 2014, you were getting 40% of United Healthcare's patients for that procedure in your market. In 2016 or 2017, you were getting, I think it was 60 to 70% of United's patient population. What is that worth to you? That delta was created through a number of shared savings, narrow network type contracts that we signed throughout those 2 to 3 years. I just pulled one example. You look at these 2 procedures, both cardiac. You see the leaked procedures. You could look at this as an opportunity or a liability. The payment, so not the overall profit, but the payment, you can see it was $13,000 and $30,000, equated about $1.2 million worth of business that's either coming to you or leaking away. Again, then it becomes a margin game, right? lowering your expenses so that you can capture most of that. But that's, a very simple example. This is real data over the course of a few years that leaked out of the system, went to your competitor, and clinical integrated networks are a way to kind of stop that, or at least create the resources to prevent that from happening. Convenience and transparency is a critical success factor for patients. See, 34% of employees that had a deductible of $1,000 or more in 2014, now that's 51%. You're seeing retail clinics get involved. You're seeing Walgreens partners with over 8 health systems and 142 clinics. I thought the bottom right one was an interesting fact. Freestanding EDs grew by 236% in Texas since 2012, even though that prices are 10 times higher than urgent cares. That was kind of a head scratcher, but I think convenience is a driving force for the patients that are there. I think depending on the acuity, I think we're in the process of running the procedures and the price point of which we're seeing consumers look at price. But for your day-to-day things that your chronic care management would intake, the consumers are definitely looking more for who can see me the quickest. I've made a joke about me being sick, going to an urgent care and getting a Z-Pack numerous times to a group of physicians. I know better than to do that here, so I'll keep going. Sites of care is changing. I've got 2 younger brothers that are in medicine. One's a OBGYN, and the other's a, huh?
I said that one won't help you much.
No, not there. And the other's he just actually matched. I guess match day was on Friday. He matched at UPMC doing ENT. He might help. But we have pretty lively discussions about, because I'm coming from the business side, he's coming from the clinical side, so we don't get along very well. So the sites of care is changing from the primary care services. You see that in primary care services, you got virtual care, virtual health. The regulatory landscape of virtual health is transforming, I'd say, daily. California, you got Kaiser Permanente going from, they want to go from, I think, 20% of their primary care visits are telehealth to, I think, 70%. It's a dramatic shift in what they're looking at. Certainly, there are reasons for and against it, but the reality is technology is transitioning the way providers interact with patients. And if your organization isn't adopting new models, you risk patient coming to you, even if you're a high-quality physician. And that's the reality of the situation, and certainly there's an aspect there. Again, I would say that's market-dependent right now with telehealth, because some payers, some employers are compensating for that, and it's very clear. I'd say other ones, it's not as clear. California, it just so happens to be. But we all know that's a very different market landscape. Urgent cares, that's critical. You're seeing health systems have the discussions with their primary care networks. Hey, do we purchase an urgent care? Do we create are you okay with that? I mean, it's a discussion that may not make 100% business sense, but it may make more political sense to either not purchase one or purchase one. You have to have these discussions, and you got to look at the data that support it. Because with the primary care shortage, it could make sense. Other markets, when a health system purchases an urgent care system, primary care, look at that as competition. So again, it's those discussions that need to be transparent. You got to keep the data simple, and you go through those hopefully in a good way. Maturity of value-based contracts. So you have to manage your revenue portfolio. There was a discussion earlier in one of the previous sessions around readmissions, and the CFO is saying I get paid for readmissions, right? So a lot of the contracts for the health systems are still fee-for-service. Doesn't mean they don't get penalized for certain areas, but they are fee-for-service. Others are value-based. You have to look at this as a balanced revenue portfolio. Some of yours needs to stay fee for service. Some of them needs to go to value. You've got to understand where the tipping point is, when you need to tip, which populations. You can't, it's almost as if you can't do it population by population because you're not going to treat your patients differently depending on who the payer is. It's definitely disease-based, but that's the discussion that you just need to have. I would recommend that if you're going to tip to more value-based, you do it very methodically and slowly in the beginning. But once you're confident as an organization, you need to tip quickly, because then if you only signed 1 or 2 value-based contracts around improving readmission scores, hospital acquiring conditions, the other payers are benefiting off of the back of the 1 or 2 value-based contracts that you've signed, and you haven't maximized the bonuses that you can get from the other payers. Does that make sense? At least how you want to manage that? Okay. So there's a point at which you need to tip quickly, but you need to be methodical about how you do that. Unfortunately, a lot of commercial payers now are mandating in these negotiations that in year 3 or year 4, you need to go to downside risk. So when you're signing these contracts, the upside's great. You're getting the bonuses, but as soon as year 3 hits, year 4 hits, you've done a lot of work on the population, and all of a sudden you've gotten a lot of the waste out, but now you're going to downside. It's a tricky thing to go about. All right, finding your runway. So when I'm talking about tipping, you can see, and over the last few discussions, we've talked about pay for performance, shared savings, shared risk, capitation. That we won't go through that, but you can see the Medicare Shared Savings Program, ACO. Everybody familiar with that, at least conceptually, what that is? Anybody not? I guess by a show of hands. Okay, great. So I'll skip that one. Medicare Advantage, primary care and care coordination, capture risk stratification, like I said, about the coding documentation, and then build patient engagement platforms. So reducing the gaps in care. Medicaid managed care, customize your approach to local communities, manage the high need, high cost population. We were talking about the indigent, right? If you think you're not at risk for them, I don't want to tell you guys you're wrong, but they're going to come to your facility. They're going to come to your hospital. You need to have a strategy to take care of those populations. We talked about patient-centered medical home. We don't need to go through that. You see the bundled payments. Select bundles based on your most unmanaged diagnoses. There is arbitrage within bundled payment programs. You just need to find it. There are ways where your organization is performing better in some procedures across the continuum. Your payers know that. Once you have the information to have that negotiation, that's an important discussion point to have, because you're probably doing it better on a regional scale than others. Now, those procedures aren't the same from organization to organization, but you should at least know what those are. Does that make sense? Okay, great. You're not talking to your physician, someone else is. So certainly there's a lot of competition right now. There's a lot of transitions away. We're seeing compensation scales change. Incentives are shifting. Payments are different, made differently. With acquisitions, you're seeing a lot of either disgruntled stakeholders with acquisitions or happy stakeholders. So you're just seeing a lot of shifts right now. Value-based care must be delivered across key elements. So I won't go through each one of these sub-bullets just for the sake of time, but you want to align your economic incentives, assure appropriate care management is in place. You want to streamline and connect your IT platforms, organize a comprehensive provider network. That's the communication channels, really. And then understand your defined population. Start small and then grow. Your population doesn't need to be a defined geography. It could be a disease state. Just start to understanding where the information you are getting is the best. Go from there. So stepwise approach to negotiation. So you always have those discussions around a multi-year agreement, which is what I was talking about in terms of pushing you more towards downside risk. Narrow network infrastructure with mutual approvals. That requires network adequacy if you're going to have those discussions. Scope of delegated responsibilities around administrative and clinical services that are going to be provided. Full data sharing that is timely, accurate, and formatted for both parties. This, number 4, is where I see a lot of these fall apart. You sign the contracts, you're saying the payer is going to send you information. First report you get is 6 months in. It's a 1-year contract. Good luck with that. But it's the reality of the situation. I'll be honest and tell you that I thought the payers were much more organized than they actually are. Even the payers don't have the information around some of the populations that you'd want. So having that discussion on the front end, understanding what reports, what data is going to be sent at what time, in what format, that's a deal breaker for me if I'm helping a provider negotiate a value-based care contract and we can't even see the format that we're going to get some of the data in. Prospective and retrospective. Does that ring a bell to anybody? So prospective is, well, here I'll talk with, prospective is you lock in, it's all about member assignment and attribution. Okay, so what is the population that you're impacting? Population shifts throughout the year, either in your network, outside of your network. You could either lock that up on the front end and say, hey, it's these 50 patients. Or you can say, you know what, we're going to take care of all of our patients this way. That might be the 50 patients that are in the population or under your insurance product today, but 12 months from now, it could be 46 or it could be 100. But it's all it is the patients that see our physicians. Does that make sense? That will be the driver of the quality and the cost thresholds that we create. Quality metrics, quality targets are generally used as a trigger. So if you don't hit your quality metrics, you don't get a shared savings. Said a different way, if you save a bunch of money but you kill a bunch of people, you're not getting paid. I'm trying to we're at the end of the day, guys. We're just trying to mutually agreed upon quality targets, and quality measures with targets must be agreed upon in advance, especially in regards to area and region. Make sense? All right, so we're going to go through a case study of an organization in the Southeast that was in a single payer dominated state. And what they wanted to do was take leverage away from the single payer in their value-based care strategy. So they started with the hospital efficiency program, which I described a little earlier, around creating a defined value for certain metrics that only the hospital and the CIN agree to. And the health system pays the CIN a set fee for any quality improvements or cost savings that are created. But they can use that pilot program either to say, hey, our physician network was able to move the needle on these 5 things, or they weren't. And then they went to a lot of the MA programs. The MA programs wanted to get into, get and enhance their covered life within the geography that we were working in. And so they were able to negotiate pretty good pay-for-performance type agreements with the MA plans. And then that turned into a Medicare shared savings contract. So again, in a single payer-dominated state, they're able to enhance their covered lives significantly just by targeting their own employees, MA. Now they're in Medicare. And finally, they were able to get the single payer to at least come to the table and have a discussion because it was eating into some of their covered lives. That was a significant win for them. It took 5-6 years. but they were able to do that. You can see some outcomes: distributed value-based payments to primary care physicians and access of 15,000, and improved percentage capture of number 2 and 3 payers in the market by 7% to 10%. A lot of win there. Certainly key areas. This is a distribution methodology. We do distribution methodologies for these value-based contracts. Just, I think the health system realizes that if they create a bad distribution methodology, they'd rather blame a consultant than themselves. And so we get thrown in to do that. And it's funny. If everybody's disappointed after a distribution methodology is created, you probably created a pretty good one. So you can see the contracts are coming through the CIN, the administrative fee. So 17%. That's arbitrary. We put 17% on this one. This is a real distribution methodology that we created. It could be based on operational expenses to the clinical integrated network. It could be based on what volume is reduced at the health system. I mean, there's a number of ways to look at that. And then you could look the hospital, primary care, and the specialists as a part of this network. The hospital was saying, look, if we're really successful on value, we're going to drive patients away from the acute setting. What is that worth to us? Primary care and the specialists said, okay, there was a number of models that kind of went through this, but we came up with 33%. And that was the dashboard that was on the hospital side to get that 33%. Primary care, they got 25, specialists got 25. The kicker here is that there were a lot more specialists than primary care, so even though the percents are equal, the distribution of the primary care was significantly more on this. And they were tracked on their attributed lives, their annual wellness visits, and then medical management participation. You can see specialists were paid on their committee involvement, their shared information. Did they share information? Link in, and then their medical management participation as well. That's just a redundant one. So now we're at value-based care agreement, performance rewards vary in magnitude. So shared savings, primary care share in a portion of the savings pool generated by increased efficiency. The size of the total pool is determined by overall performance. Certainly it's risk adjusted. You could do reporting bonuses, which is more pay for performance, quality, and then there's a care management component to that as well. Because in theory, you're taking that ownership away from the insurer onto yourself as the organization. So what's the value of that? You can see some examples there and in your handouts. So it's really transitioned the strategic planning process for health systems. In the past, change management has been, okay, where are we going? Let's do an internal market assessment, strategy formation, some action steps, and then monitor how we're doing. Now you're getting into the value aspect of it. And there was a question asked, I forget which presentation, but it was around what's the financial win for some of the outcomes that are being generated. If you don't have a financial win, it's very difficult to sell, but certainly just having the outcomes, that's a prerequisite to getting patients. So you definitely want that as an aspect of it. But the clinical integrated network, the ones that I've seen be successful, can quantify the value that they're adding. You're seeing the benchmark performance. You're seeing system of care partners accelerate. That's just a fancy way of saying your partnerships are enhanced. You're creating partnerships on both sides with the post-acute, community-based, and then other growth in clinical operations, and then certainly defining accountability, and then partnerships and governance. So I went a little bit quick through that. The lessons learned, connectivity and real-time data access is critical to managing populations. Funds flow models, again, need to be simple. You can very quickly get complex with those. There's no conversation. Let's just say I've been in conversations where a primary care physician is saying that the patient is theirs, but the orthopedic surgeon is the one that did the work. But the primary care physician referred that patient to the orthopedic surgeon. So who owns the patient? I'm not getting in the middle of that. So, so when you're talking about funds flow, and all of a sudden there was either a bad outcome or good outcome, how do you give all credit to one of the specialist or the primary? It's just it's a balancing act. And so, having physicians at the table that are driving that and then making sure that it's equitable and simple is the better way to go on those discussions. Quality may be measured by process-based tasks. Did you show up for a meeting? Did you do X, Y, or Z? And that eventually leads to outcome. Because the issue is, if you're going outcome first and your data isn't right, or it's not exact, or it's not where you want it to be, it's very difficult to create credibility after you've shown providers inaccurate data. So that's why you say you kind of go from process to outcome. Only take downside within your organization and market require it, and then engage clinical staff in the discussions.